professor in many universities, and I'm honored to say that he's also in one of these universities, our University of Ferrara in Italy. At present, Juan Carlos is president of the Spanish Society of Orthodontists and ambassador of the AAO around the world. He has been authoring many articles and chapters, and he has given lectures all around the world. His private practice is based in Santiago de Compostela in Spain, and his title of the webinar today is The Key Factors to Improve Frontal and Lateral Projection of the Smile in Adult Patients. So without further delay, I would like to tell everyone that please, you are welcome to use the Q&A section in our Zoom session in order to write any questions you have about the presentation of Juan Carlos, and that we will have an open question time just at the end of the webinar from Juan Carlos himself. And with this, please, ladies and gentlemen, again, let me introduce you and welcome Dr. Juan Carlos Perez Varela.
Hello, can you see my screen? Yes? Hello, good afternoon from Spain. Thank you very much, Nick. Thank you very much, Cesare, for the kind invitation. It's a real pleasure for me to be here today. During many years, we treat many patients in our offices. And like this patient, our goal was to combine orthopedic procedures with orthodontics and correct cases like this. The case of this kid was a skeletal class 3. We treat with orthopedic approach and after braces, and we analyze at the end the plaster models.
Juan Carlos, sorry, we are not seeing your screen yet.
Oh, sorry. So I go back. Let me check again. Can you see it right now?
We have it now. It's perfect.
Wait a minute. Okay, can you see it right now?
Yes, it's perfect, Juan Carlos.
Perfect. During many years, as I mentioned before, we treat many kids at the office, like this patient. This lady, this girl was a skeletal class 3. We combined orthopedic approach with orthodontics. And at the end, we analyze the radiographs, the photographs, and the plaster models. And right now, the situation is quite different for orthodontics. Around 60% of my patients are adults. And besides this, a significant percentage of them have skeletal malocclusions. If we agree as orthodontists that the objectives of our treatment or orthodontic treatments are the following: to try to improve the alignment, to try to improve the occlusion and the function, or of course to try to improve smile aesthetics, to try to get the best stability in spite of the passing of the time. Of course, we need that the patients finish satisfied. In many cases, we are going to improve facial aesthetics, as we are going to see, mainly when we are going to combine orthodontics and orthodontic surgery, and of course, with a good periodontal status. And we are very lucky because we can use CBCT to double check the position of the roots in the middle of the alveolar bone. To try to get these objectives, in many cases, like the case of this lady, we need to do a bimaxillary surgery approach. At the beginning, he came to my office with a skeletal open bite, with a skeletal class 3. We performed a bimaxillary approach, and we got all the treatment objectives that I mentioned before. In other cases like this, we need to do bimaxillary surgery, of course, orthodontics, periodontics, and we need to finish with prosthodontics. But if you think about the main motivation of the patients for coming to our offices, what do you think is the main motivation for the patient to come into our office? If we go to the literature and we use any kind of search engine like PubMed, for example, and we write orthodontic treatment objectives, try to look for main concern, we are going to find that the main concern of the patients for coming to our offices is to try to improve smile aesthetics. And it's very interesting because if we take into account this article published in Angler Orthodontist 2014, we are going to see that many patients saw his feelings about the ortho treatments with the social media. For the reason, it's very important to try to finish the cases with nice smiles, and of course, that most of the patients finish satisfied. Like the case of this lady that came to my office, Teresa, that normally she posts a lot of photographs and all the time smiling. It's very good for our business. But the question is that the perception that we have about our facial aesthetics is this. When we saw ourselves in front of a mirror, so we can check only the frontal view of the smile. But it's quite different because the perception that have the rest of the people for a smile is in the frontal and in the lateral projection. For the reason, it's very easy to understand that articles like this demonstrate that the lateral projection of the smile is crucial in the planning, diagnosis, and to analyze at the end of the treatment. For the reason, we normally analyze the frontal and lateral projection of the smile at the beginning of the treatment, in the middle of the treatment, before they finish the treatment, and at the end of the treatment. And of course, for us, the goal is to try to improve the frontal and the lateral projection of the smile. In this conference, we're going to analyze key factors in order to improve smile aesthetics in frontal and in lateral projection. And for me, in most of the cases, as you are going to see, it's more difficult to improve the lateral projection of the smile. To try to improve the lateral projection of the smile, in many cases, like the case of this guy, we need to do a multidisciplinary treatment, sometimes with orthodontic surgery, other with cosmetics, and other with prosthodontics. The first thing is to analyze what factors make a beautiful smile. I would like to divide in frontal projection factors and in the lateral projection factors. For me, it's very important in the frontal projection, these 5 factors: the relation of the teeth with the lips, the tooth exposure, the correlation of the upper midline with the lower midline and with the facial midline, of course, the smile width, and the gingival margins. I'm going to focus my attention in this conference in the smile width, due to the fact that for me it's very important in order to improve the smile aesthetics at the end of the treatment. In cases where there are a sagittal hypoplasia of the maxilla, a transversal hypoplasia of the maxilla, or aesthetic negative torque of the posterior teeth, we are going to see the black spaces and buccal corridors. It's very clear in the literature that if the distance between the teeth and the labial corridors is very big, we are going to decrease the smile width and the smile aesthetics at the end of the treatment. So, our duty, of course, is to try to improve the smile width at the end of the treatment. If we try to summarize the factors that affect the smile width, I try to highlight 3 factors: the maxillary width, the sagittal maxillary position, and the torque of the posterior teeth. This last factor was very well described in different articles and conference from our friend Bjorn Thakrisson. In this article, he highlighted the importance of the buccal writing of canine and premolars to try to improve smile aesthetic, just contrary to the expansion of the arches. He concluded that to try to improve smile aesthetics and the smile width, it's very important to arrive the canines and premolars and to try to avoid the expansion of the arches. For this reason, in the last year, we used this prescription. We call high torque prescription. Positive 7 on the canine, 0 on the premolars, and 0 on the upper molars. Our idea is to try to arrive the canines and premolars, to try to minimize the buccal corridors, and to try to increase the smile width, and of course, finish with a nice and a beautiful smile. This is the idea. We can see the idea in this diagram. We can see the canines just in the middle of the alveolar bone. Our idea is to align and to set a 19 by 25 steel wire to try to arrive the canines, to set the roots in the middle of the alveolar bone and minimize the buccal corridors. The question is, if we are going to arrive the canines and premolars, is only a question of aesthetics? For me, it's not only a question of aesthetics. It's also occlusion and biology. I don't like this occlusion. I finished many cases with this occlusion during many years because at that moment we were using a very negative TOR prescription. We finished the cases with a good occlusion for the vestibular part, but bad contact for the lingual part. Our idea nowadays is to try to arrive the canine, premolars, and molars and obtain nice contacts for the vestibular and for the lingual. And we call this complete occlusion. Nice contacts for the vestibular and nice contacts for the lingual. You can see here in this diagram. And for me, nowadays, it's an objective in my office to try to do it a complete occlusion. Because I know that I'm able to get a complete occlusion, I am going to arrive the canines and premolars, I am going to increase the smile width, I am going to finish with the roots just in the middle of the alveolar bone, the best position in the middle of the alveolar bone. Regarding the lateral projection of the smile, I am going to highlight the importance of two factors: the anterior torque of the upper incisors and the sagittal maxillary position. Of course, we would like to finish all the cases with a nice inclination of the upper incisors. Normally, it could be around 110 and 120, because we have the evidence that if we finish with a nice torque in the upper central incisors, we are going to finish the case with a nice lateral projection of the smile. For this reason, we prefer to use high torque in the upper central incisors and in the lateral incisors. And we have the evidence that if we finish with a nice torque in the upper incisors, we are going to improve the lateral projection of the smile and the projection of the lips. The second factor is the sagittal maxillary position. And for me, it's one of the keys in our population. And after, I'm going to explain why. In this interesting article published in American Journal of Orthodontics, they tried to move with a software the maxillary incisors forward and backward. And they were analyzed for lay people, and they found that the more attractive profiles were with a protrusive position of the maxillary incisors or normal position of the maxillary incisors. And we must take into account that a significant percent of our patients are skeletal baroretrusians. I'm speaking about Europe, United States, in many other countries. In my country, for example, we're going to treat many skeletal class 2 patients with skeletal baroretrusion, skeletal class 3 with skeletal baroretrusion, even skeletal open bite with skeletal baroretrusion. For this reason, we know that if we want to improve the lateral projection of the smile, we need to move forward the upper incisors. And this is not so easy. So what do you think is the ideal maxillary position to try to improve facial aesthetics and the lateral projection of the smile? For example, in a case like this lady with a skeletal class 3 and a significant reduction in the maxilla, what do you think is the ideal position to set the upper temporal incisors? Of course, and we have the evidence that if we move forward the upper incisors, we are going to improve the lateral projection of the smile, and we are going to improve the profile. But the question is, how much? Of course, I would like to highlight this article, the soft tissue cephalometric analysis, the true vertical line. It was published for Arnett in American Journal of Orthodontics in 1999. He highlighted the importance of the true vertical line, but we prefer to use this line. It's based in the idea of my friend Federico Hernandez Alfaro. We call this idea soft tissue nation. This is the line that passed from soft tissue nation, and we did a small research to try to validate this idea. We use a line perpendicular to Frankfurt, and in our research, we found that the nicer braces finish with the upper incisors 3.4 millimeters in front of this line, and the lower incisors touching this line, the soft tissue nasal line. For the reason, we are going to use this line like orthodontic objective to finish the most of my cases. And sometimes it's not so easy. Sometimes we need to do a surgical approach to try to get this position. So as you can see in this case, this lady came to my office with a significant skeletal class 2, and we moved the maxilla and the mandible forward to try to finish with the upper central incisor and the lower incisors in the position that I mentioned before. And of course, we have the evidence. I see every day in my office that if we finish with the upper central incisors in front of this line and the lower incisors touching this line, we can see very nice lateral projection of the smile. For the reason, I am going to try to get this goal in most of my patients. But sometimes it's not so easy if we are not able to perform a surgical approach. To try to illustrate these concepts, I would like to show with you 4 patients. All of them, as you can see, are adult patients, all of them with skeletal malocclusions, and all of them with problems in the frontal and lateral projection of the smile. When we're going to perform a multidisciplinary treatment, our objectives are always the same. First, to try to improve the function and the TNJ. Second, to improve the health. To try to improve the periodontal and dental status. And after, we are going to focus our attention into trying to improve aesthetics, facial aesthetics, and dental aesthetics. We're going to begin with these both patients. Both of them are adults, as you can see. Both of them had a skeletal class 2 with a skeletal biretrusion. Both of them, as you see in detail, have an inclination of the occlusal plane. And in both cases, we want to improve the frontal and lateral projection of the smile. Francisco arrived to my office when he was 40 years old. He had TNJ problems, breathing problems. Of course, he wanted to improve smile aesthetics and facial aesthetics. He was treated with these braces during 1 year. Of course, you can see that the inclination of the occlusal plane. We cannot see a very nice frontal projection of the smile. We can see an open bite, significant retrusion of the mandible, poor lateral projection of the smile. You can see the retrusion of the mandible and retrusion of the maxilla. It's a skeletal biretrusion with a skeletal open bite and a skeletal class 2. This was the situation when he arrived to my office, only with braces in the upper arch, TNJ problems, periodontal problems. We follow this sequence to try to improve the function, the TNG, to try to improve the periodontal and dental status, and after focus attention to try to improve aesthetics. First, we debone these braces. We send the patient to the to do a periodontal treatment. This is just after the periodontal treatment. And when we debone the braces, you can see the open bite, deviation of the mandible to the left side, inclination of the occlusal plane. You can see how decreased is the smile width in this patient. Poor lateral projection of the smile, severe retrusion of the mandible, long face. You can see the situation before beginning the case. If we take into account this article from the group of orthodontists, my friends from Luca Lombardo and Siciliana from Ferrara University, they tried to look for relations between different skeletal malocclusions and TNJ problems. They found a strong correlation between skeletal class 2, skeletal open bite, and TNJ problems, because these patients try to advance the mandible, looking for contacts, and at the end, they have a lot of TNJ problems. This is the R sequence that we normally use when we treat the patients with braces. Of course, if you see in detail, in the 95% of the cases, we're going to use only 4 arches. Normally, we align with a 16 nickel titanium. We level with a 17 by 25 nickel titanium, or arch wall resistant 19 by 25 steel wire. And we normally finish the most of the cases with an 18 steel wire with a lot of bands. We are beginning the case. In this moment, the patient is using a lower spleen. We send the patient to physiotherapy. Normally, after we level the teeth with a 17 by 25, we normally do a new study with new records and new graduates. In this situation, we set a 17 by 25 nickel titanium. The patient continues using the lower spleen. We decide to close the upper spaces of the molars, and we reopen the lower spaces to set 2 implants. In this moment, we are using a 17 by 25 in the upper and 17.25 in the lower. In this moment, we decide with the patient to do a surgery early, to do a bimaxillary surgery approach, taking into account the patient. We decide to do a surgery early. Normally we did an intraoral scan, a CBCT. We join both images. We obtain these images. You can see a long face patient with a bimaxillary retrusion. The maxilla is retrude and the mandible is retrude. It's the typical long face with a skeletal barrier retrusion. And we have the evidence that, as I mentioned before, that if we want to improve the frontal and lateral projection of the smile, we need to advance the maxilla and the mandible, and we need to arrive the canines and premolars. Looking for the guide that I mentioned before, looking to finishing with the upper incisor, upper central incisors in front of the soft tissue nasal line, 3-4 millimeters in front of this line, and the lower incisors touching this line. You can see the surgery that we perform in the computer. We advance the maxilla to finish with the upper central incisors in front of the soft tissue nasal line and the lower incisors touching this line. You can see the surgery that we perform. We advance the maxilla and the mandible with a counter-cross clockwise rotation of the mandible. We perform a mentoplasty, as you can see here. You can see how we advance the maxilla and the mandible at the same time. We did a mentoplasty to try to improve the profile. Of course, with this surgical movement, we are going to improve a lot the profile, the lateral projection of the smile, and of course, the upper airway. This is photographies just after the surgery. You can see how we improve the profile of the patient. After this, we decide to prepare the case to set 2 implants. In our protocol, we prefer to open the space for the implants, set implants. After set provisional crowns, set the elastics to try to improve the occlusion with the resin provisional crowns, and to set the definite crowns after we remove the braces. This is the patient 1 week after we remove the braces. You notice how we close up and bite, how we obtain a nice coordination of the upper midline with the facial midline and the lower, how we equilibrate the occlusal plane, how we improve the lateral projection and the frontal projection of the smile. The goal of the most of my patients, as I mentioned before. This is the occlusion after we finish the case. This is the moment that we send the patient to the prosthodontics to set the definite crowns. After the prosthodontists are going to set the definite crowns. These are the changes before and after with the bimaxillary surgery approach. how we improve the smile aesthetics in the frontal, as you can see here, because we advance the maxilla, we control the torque of the upper teeth, and we align the canines and premolars to try to improve the smile width. You notice how we improve the profile of the patient. You can see the changes before and after the bimaxillary surgery approach, and how we improve the lateral projection of the smile because we change the two factors that I mentioned before. The torque of the upper teeth, the upper incisors, and the sagittal position of the maxilla. The two main factors to try to improve the lateral projection of the smile. And of course, we improve the upper weight balloon. The patient was very happy with the result, and we passed from physiotherapy, periodontal treatment, orthodontic treatment, orthodontic surgery, implants, and prosthodontics. This was the case of Begonia. She arrived to my office when she was 45 years old. She came with TNJ problems, breathing problems, and of course, aesthetic problem. You notice the significant deviation of the upper midline to the left, significant transversal problem in the maxilla. You can see how decreased is the smile width. And of course, if you see in detail, you are going to realize that Begonia had a significant skeletal bile retrusion. This was an intraoral situation. She lost the lower molars, significant deviation of the upper midline to the left. You can also see here the upper left lateral incisor, significant transversal problem, crowding in the upper and in the lower. We decided to reopen the lower spaces to set implants in our plan of treatment. You can see the lateral incisor in the lingual part without any kind of space to try to align it. When we analyze the profile of the patient and the lateral radiograph, we can confirm that she had a skeletal class 2 with a significant retrusion of the maxilla and the mandible, a significant skeletal bile retrusion. Of course, we're going to try to improve the function, the TNG, of course, the periodontal and dental status, and the aesthetics. I mention again the article from Luca and Giuseppe Siciliani. In this case, contrary to the other, we began the case with an upper spleen, lower braces, because when we have a severe transversal problem, we always try to decompensate the lower arch to try to measure the real transversal problem. For the reason in this case, we prefer to begin the case with an upper spleen and lower braces. We send the patient to physiotherapy, and we began with a 16 nickel titanium in the lower. After we pass on a 17 by 25 nickel titanium to level the teeth. And at this point, after 4 or 5 months, we take new records. This is the situation of the patients. You notice how significant is the transversal problem in this patient, significant deviation of the upper midline to the left. At this moment, we like to do a CBCT to measure the real transversal problem. It's a significant hypoplasia of the maxilla in the transversal and sagittal dimension, significant retrusion of the maxilla and the mandible, significant transversal problem in the maxilla. We explain all these problems to the patient, and of course the ideal treatment for this patient could be to do first SR technique due to the fact that the transversal problem is bigger than 7 millimeters, and after to try to perform a bimaxillary surgery approach. Of course, set 2 implants for the molars and to try to improve aesthetics with some cosmetics. She rejected the orthodontic surgery, so we did a protocol that we normally do in these cases, and we call SABAME and TATS. SABAME is surgical assisted bone and coral maxillary expander. The idea is to try to do this surgical technique that is called surgical assisted bone and coral maxillary expander. It's described from my friend Federico Hernandez Alfaro in Journal Oral Maxillofacial Surgery 2009. We call this minimal invasive surgical assisted rapid palatal expansion. is a protocol with local anesthesia and sedation 25 minutes. We combine this with bones anchored maxillary expander. Normally we use the power expander. It's a expander that I'm going to explain in another case. You can see the patient, we are turning the screw, we are expanding the maxilla. You can see the big diastema. Normally we began to turn the screw 1 week after we did the SAR technique. And our idea is to try to start activation 1 week later and after ring between 0.5 millimeters or 1 millimeters. You can see how we are expanding the maxilla without inclination of the teeth, but it's nice to generate this space, to create a space to align the lateral incisor. And we combine the sabame with some touch to try to equilibrate the occlusal plane. Taking advantage of the local anesthesia and sedation procedure, we're going to combine with touch to try to equilibrate the occlusal plane. We're going to, after one or 2 months, it's better to wait 2 months to bond the upper braces. We bond the upper braces. We're going to move the upper incisor to the right side to try to create space to align the lateral incisor. We are going to, at this point, we solve the transversal problem. We are trying to coordinate the upper dental midline with the lower dental midline. We prepare the lower spaces to set an implant. You can see how we are creating space to the lateral incisor. You can see how we are obtaining the nice coordination of the upper midline with the lower. We are moving the teeth very slowly. At this point, we prefer to set a coil spring to create more space. You can see at this moment we are getting class 1 canine and molar occlusion. After we move the lateral incisor to the arch, we need to do a vestibular root torque. This is the last movement of the lateral incisors. We turn down the bracket to try to move the root to the vestibular area. At this point, you notice how we got the coordination of the upper midline with the lower. We solve the transversal problem. We are preparing the case to set an implant on the lower right molar. You can see here the patient with the lateral incisor bracket turned down to try to move the root forward. After we move the root, we bond the lateral incisor bracket again. Of course, in this case, we are going to try to level the gingival margins because after we need some cosmetics to try to improve the smile arch. In this moment, you can see how we increase the smile width due to the fact that we expand the maxilla and we arrive the canines and premolars. We take a nice coordination of the upper midline with the lower. At this point, it's a very easy case to finish. We have a molar and canine class 1 on both sides. On the right side, we are preparing the case to set an implant. As I mentioned before, we prefer to open the space, set the implant. 3 months later, we set a resin crown, provisional crown. We improve the occlusion over this provisional crown, and we prefer to set the definite crown after we finish the case. You can see the steps here. We prepare the space. We set the implant. We set a provisional resin crown. We use sole elastics in this provisional crown to try to improve the occlusion and get molar and canine class 1 on both sides. At this moment, you notice how we obtain a nice coordination of the upper midline with the lower, how we have a molar and canine class 1 on the right side over the provisional resin crown. Before the bond brackets, we normally took photographs from the frontal and lateral projection of the smile. We can see in this moment that we increase dramatically the smile width. We obtain a nice coordination of the upper midline with the lower. You notice how we improve the lateral projection of the smile. Of course, in this case, the best approach could be to do a bimaxillary surgery advanced like in the case that I presented before, to try to improve even more the profile of the patient and the lateral projection of the smile. When we remove the braces, we normally do some gingivectomy to try to improve the smile arch. We do some cosmetics, some composites. This is the final result with some small composites. You notice how we improve lateral projection of the smile only with the control of the torque of the upper central incisors. Of course, as I mentioned before, the ideal approach for this patient could be to do a bimaxillary surgery at once. And we finish the case with an affectable occlusion with molar and canine class 1 on both sides, as you can see here, and with the molar, class 1 molar on the right over the implant. You can see the changes before and after, how we expand the maxilla with the local anesthesia procedure, how we coordinate the upper midline with the lower, how we gain space to set the lateral incisors, and how we dramatically improve the frontal projection of the smile, due to the fact that we change two of the factors, the maxillary width and the torque of the canines and premolars. And of course, we improve partially the lateral projection of the smile, because we didn't improve one of the factors. We didn't improve the sagittal maxillary position. It could be better to try to move the maxilla forward in order to improve better, even more, the lateral projection of the smile. And if we compare the upper airway balloon at the beginning, at the end of the treatment, we are going to realize that due to the fact that we expand the maxilla around 10 millimeters, we improve a lot the upper airway balloon. And of course, the patient is very happy, in spite that we finish the case with a skeletal bimaxillary retrusion. I'm going to finish with two cases. Issues in detail are quite similar, both of them. One is a lady, of course, and one is a boy. But if you see in detail, you're going to realize that both of them were skeletal class 3, both of them with a dental deviation, maxillary deviation to the right, skeletal asymmetry, tendency to do open bite, and difficult cases, and both of them with T&J problems. The first one was Sandra. Sandra came to my office with T&J problems, breathing problems. Of course, she wanted to improve smile aesthetics, significant deviation of the upper midline to the right. She had a previous orthodontic treatment. They extract the upper right premolar. She finished with a clear deviation of the upper midline to the right, deviation of the mandible to the left side, significant transversal problem, inclination of the occlusal plane, asymmetry of the face. You can see in these images the significant retrusion of the maxilla. Of course, to try to improve smile aesthetics in frontal and lateral, we need to improve smile width, to improve the frontal projection, and we need to improve the sagittal position of the maxilla and the torque of the upper teeth to try to improve the lateral projection of the smile. You can see here in detail the lack of malar support for the retrusion of the maxilla. Infrarally, she had a molar and canine class 3 on both sides, significant deviation of the mandible, significant transversal problem. You notice the deviation of the upper midline to the right, the deviation of the lower midline to the left. When we check the lateral gradual, we confirm a skeletal class 3 with a significant reduction of the mandible. Of course, in these cases, there is a strong correlation between transversal problem and T&J symptoms. Like in the other cases, we're going to try to improve the function, the T&J, of course, the periodontal and dental status, and of course, the main concern of the patient, to try to improve facial aesthetics and smile aesthetics. In our protocol, when we have a patient with the skeletal problems in the transversal problem in other planes of the space, we have two options: to try to solve the case only with a segmental effort, or to do in two steps. First, to do a SAR technique, and after a bimaxillary approach. Normally, when we have a transversal problem, as I mentioned before, due to the fact that the biology tried to compensate this transversal problem with the lower lingual inclination. First, we propose the patient to use an upper spleen. We decompensate the lower brackets. In most of these cases with skeletal clustering, we know and we see every day in the office that many of them, they have a cortical bone on the lower canines and incisors. In many of these cases, we need to finish with a gingival graft. Of course, we need to abride the lower teeth. You can see in this image the significant lingual inclination of the premolars and molars to try to compensate